This is the last session by Dr. T.S. Rao on disorder related to sexuality and gender identity in ICD-11. This session will be chaired by Professor Ajit Awasthi. Professor Ajit Awasthi, former head of or Department of Psychiatry, PGIMER, Chandigarh. His area of interest are schizophrenia, anxiety, mood disorder, human sexuality and its dysfunction, and consultation liaison in psychiatry. Sir has more than 400 papers and 40 funded research projects, and Sir edited 16 books, 60 book chapters, and delivered more than 450 scientific lectures in his credit. Sir has received 41 awards, including the prestigious Maftiya Award and Dr. Vidyasagar Award, D.L. Murthy Rao Oration of IPS, and Venkava Rao Oration of ISP. Sir, in past, Sir was president of Indian Association for Geriatric Mental Health in year 2017 to 19, and a chairperson of Indian Psychiatry Society Research and Education Foundation in 2011, and president of Indian Psychiatric Society in 2010. Son is convener and co-chair of task force of IPS to create clinical practice guidelines. And second chairperson of this session is Dr. Swapanji Sahu, who is currently working as assistant professor in Department of Psychiatry, PGIMER, Chandigarh. Sir's area of interest is psychotic disorder, consultation liaison psychiatry, psychosexual disorder, geriatrics psychiatry, and psychopharmacology. Sir has 151 publication and 14 book chapters to his credit, and Sir has received Srimati Shweta Tiwari Memorial Award, Dr. J.C. Bural Award, Dr. V.K. Verma Award, Bhagwat Award, and Young Psychiatrist Award of IPS in 2020. He also received International Young Research Fellowship Award of World Psychiatric Association in 2017. Now I will request to the chairperson to introduce the speaker and for further proceedings. Thank you.
Thank you very much, Dr. Ajaypal, for the kind introduction. And Dr. Awasthi will be joining shortly. He's finding difficulty in joining, so he'll be joining. We are trying hard to that. Let me first introduce our chief speaker, Dr. T.S. Rao. We all know him very well. He's a professor of psychiatry in Department of Psychiatry, JSS Medical College and Hospital, Mysore. And his areas of interest is sexual medicine and psychiatry. He has around 321 research papers and 26 book and book chapters. He has many awards to his credit, including Marfati Award, DLN Murthy Rao Oration Award, which he received in ANSIPS 2020 at the Kolkata. And he has several posts of the Indian Psychiatric Society, also from the international societies. He is currently the Honorary General Secretary of Indian Psychiatric Society. He is the editor of Journal of Psychosexual Health. He was the former president of Indian Association of Geriatric Mental Health, and also he had been the editor of our Indian Journal of Psychiatry in 2004 and again from 2007 to 2018. And he is also the Secretary of Psychiatry and Human Sexuality section of the World Psychiatric Association. Very warm welcome, sir, and we're looking forward to hear from you on this very great topic on ICD-11 changes on the sexuality section.
Thank you. Good afternoon, everybody, and at the outset, let me recollect my association with Dr. Ajit Awasthi in particular. In fact, as a PG student, I can very vividly remember idolizing him for the major work what he was trying to do in the area of psychosexual medicine. Along with that, in fact, I had occasion to work under him for a pretty long time as editor, and as a Honorary General Secretary. I always look forward to the guidance, how to lead the society. And he has shaped and contributed to my life in very many ways. So Panjit and all the organizers of this particular program, sincere thanks for this great opportunity what you have provided. I'll start sharing the slides.
This is one. Not even. Is this the one?
No.
This is not the
Something
one.
else.
Okay. The other one.
So this one, first one.
It's not coming here.
Just stop.
If I share this, ICD sexuality. So we are sharing right now. If I press it, yes, sir.
There's the one. Okay, next slide. It's really very interesting to know that ICD-11 has become a prime source of interest, and we are looking into all the developments that have happened. I was listening to the previous lecture wherein the sleep has been made into a separate chapter, and the issues that have cropped up, whether it is good or bad or various other such aspects. And the same story applies to even the sexual disorder section, because all along you are very cozily adjusted to the sexuality section being in there in the psychiatry has been removed. And what are the advantages? What are the disadvantages? What are actually the changes? The implications of this in our clinical practice. So also maybe the research, legal, and what we basically call academic purposes, the things how they are going to work out. I'll just take about a minute or two to introduce the topic, for the simple reason that it is almost like warm up. We are all well aware that human sexuality is a diverse and complex phenomenon, and it is subject to multiple influences: biology, culture, social, and many other aspects. Even with the recent advances in many aspects, still issues are quite baffling. And one of the most important areas is actually the diagnostic classification. At the very outset, what can say is, so far, much of our work has been in terms of arbitrary or subjective criteria. We are not still clear when actually to say something normal and abnormal. The research practice, in fact, the criteria is whether to be loose or very strict and rigid. A lot of personal and individual experiences get in, and that actually vitiates a whole picture. And as we are well aware, country to country, time to time, context to context, there are a lot of differences possible how actually, in fact, we try to communicate. Of course, we are all aware that classification is one of the important aspect, because it serves three purposes. It helps in our communication, control in the sense that we can modify this particular aspect, and comprehension, we can understand what we actually were trying to talk about. In fact, the nosological diagnosis, just like in case of medicine in psychiatry, sexuality you can make, or you can distinguish from one to other by what we basically call differential diagnosis. And as we are emphatic in certain aspects so far, that multiple aspects actually impinge on actually the diagnosis, the patient, and progress, the multi-axial understanding, which has stayed very significantly for a pretty length of time in the whole of psychiatry. And when we are trying to talk about various diagnostic terminologies, there are times actually when we will be trying to look at the little picture. Maybe, for example, when we are trying to talk about intersex conditions, anatomy, physiology, neurological, the certain hormonal changes and psychological. So only a small portion, and where actually these particular categories can be actually placed to the big picture, where larger social, demographic, and such other concerns get into the picture. So it all depends in what area we are trying to look at issues. and how actually and for what purposes we are trying to look into these particular categories. When we are trying to talk about it as a multi-dimensional, many of the times we try to look at maybe medicine, surgery, OBG, dermatology, and medical such terminologies. But psychiatry in general and sexual medicine in particular, the sociology, anthropology, psychology, a lot of other medical branches, law, theology, in fact, you name it, all of these things have some role to play and to make a decision. And when we try to look at classification, the common thread between psychiatric disorders and sexual disorders was established long ago. And much of the work and credit goes to Marston and Johnson's, who proposed very agreeable classification at a particular time. In fact, the Kaplan's 3-phase, 2, in fact, the Marston and Johnson's, the 4 phases, and which actually got modified at different times in the context, we are all well aware. And at this juncture, we psychiatrists, because we are exposed to both biological aspects, psychological aspects, social aspects, maybe, in fact, this particular branch can do a very good job as far as handling these problems are concerned. I have attended a lot of maybe urological and gynecological and such other conferences also. Many of the times they are very focused with what actually they are trying to do. So psychiatry, it was there and it was a worthy place for it. And when we try to look at how actually the things have changed, there is a very limited published data supporting current diagnosis and criteria, actually what has been coined, recognized to, in fact, the current ICD-11 and DSM-5, what are the changes that have actually happened, we'll be trying to look into. If we try to look at 1990, in fact, almost every 10 years plus, actually, there used to be revision. Unfortunately, almost around 28 years, nothing really much happened is actually very surprising. But many of the changes that happened, maybe for good, and maybe certain loss and all what we have actually encountered, that this particular section has been taken off from actually psychiatric section, may be, in fact, has its own advantages and disadvantages. When we try to look at ICD-10, in fact, there is a whole category of disorders are there. One important point is actually those which are organic, which used to go into a separate category altogether of genito-urinary system and problems related to that. Two, in fact, non-organic used to be coined in various terminologies like lack or loss of desire, sexual aversion, genital response, orgasm, vaginismus and dyspareunia, excessive sexual drive, other sexual dysfunctions, unspecified sexual dysfunctions. Each of these sections have undergone marked remarkable changes. At least in certain areas, maybe the revolutionary changes have happened, and maybe that is for good. I'll try to look into each of these type of things. So when we try to look at that particular ICD-10 diagnostic categories, what is actually very apparent straight away to many of us is that there is a lack of cumulative or continuous aspects is different categories. There's a lack of distinction between male and female. Much of it is genitally focused, predominantly masculine, largely subjective. Clinically, multiple diagnoses are possible. In fact, the circular model talks about, say, if there's a desire affected, erection, or actually the ejaculation and orgasm, or even in case of females, once desire affected, the arousal to, in fact, orgasm, each of these areas may get affected, and multiple areas the problems going to be present. For example, hypoactive sexual desire disorder, 41% of the females, another one diagnosis almost in 18% of the cases. There are all the 3 phases abnormalities once actually the desire problem actually present actually has been recognized. Traditionally, we all used to the point that at least I remember very, very clearly as a young postgraduate student, almost 95% of the cases are psychological. It is there in the mind. That's what actually we were emphasized. So this traditional dichotomy between psychological and organic persisted for a long time. But there are few important points what we should remember, because once you go into the ICD-11, both partners as a unit, this is one of the extremely important component in sexual medicine classification. Individual versus couple. See, for example, a person may be having erectile problem, not in relationship, this may not create any problem at all with that. So many of these problems are actually couple related, means, in fact, they are all relationship related problems too. In fact, this is one of the aspects. Partner presented as normal. In fact, I'll try to elaborate on this particular point later in the breakout session. When somebody presents to you with certain type of problems, I still remember a young man coming and telling that he's having erectile problem, please treat me. That he had married to a lady who had a sexual aversion disorder, almost 4 years, not successful, and he was called to come home and try to perform in front of a lot of people. There is a lot of interesting developments there around that area, and ultimately he was not able to get erection, and he was labeled as erectile problem, and he was sent back. So we definitely need to look into. You might have admitted a patient for the management of erectile dysfunction, but later we realize the vaginismus problem in case of wife. So here we definitely need to keep it in mind, the relational aspects, and that's what actually going to make a whole lot of difference. And when we are trying to talk about certain types of categories, say for example, in case of men and women, there's a wide differences actually how actually they respond and how actually the things proceed. The man could be very fast on the trigger, but the female could take much longer time. This is one of the well documented this thing. And what Master Johnson presented, that in fact they are fast on the trigger. Not only that, but there is something like a refractory period. The woman takes her own sweet time to reach the peak, but then she can respond in multiple ways, and she can have multiple orgasms too. And what actually has been documented, that they can be happy and comfortable and without reaching orgasms too. In fact, permutation combinations, in fact, people have documented. And what it means is, primarily we are trying to look at physiological changes that were actually happening. People started complaining because the female sexuality is actually quite different from male sexuality, and reaching orgasm and lot many other things, in fact, it doesn't proceed the way actually the man's sexual response can be taken into consideration. The David Reed's erotic stimulus pathway is very clear, and very beautiful terminologies which have been given only to reflect on the point that, in fact, the romance and lot many other things matter much more than actually the purely question of just like man getting the erection. I'm very fond of this quoting Levine's the 7 stages in case of sexual. But I have been told to talk on what we call sexual problem areas. So also the identity related issues. And if you try to look at among the 7 categories, first three, the identity, orientation, and intention, they form the bigger group of what we basically call identity. The desire, arousal, and orgasm, what we talk about, that reflects the sexual function. But that 7th one, often which has been left out, and later, in fact, one of the WPO proposal that how actually, in fact, this particular classification need to be done. Somehow, unfortunately, this has not got incorporated in any of these classifications, that emotional satisfaction. Man and woman, the wide difference actually happens mainly because the emotional satisfaction to a great extent, that ejaculation almost equivalent to orgasm, positively reinforced, continue to sustain, whereas because this is actually not so in case of a female, often a form of duty and something need to be carried out leads to quite a bit of difficulty, and this particular aspect definitely need to be looked into. We are going to come across or emphasize on this particular point as and as we proceed, but the important point is we are somehow very negligent about this emotional satisfaction entitled along with that. What are these ICD-11 features compared to ICD-10, what people have found? There are a few structural problems while using ICD-10, and those have been solved. Now it is much easier to use than ICD-10. The systematic reliance on the use of code combinations, extension codes make ICD finally clinically relevant. Special versions are available for mental health, primary care, and certain other aspects. A multilingual presentation possible. Based on electronic foundation, in fact, the current digital age, what we are trying to talk about, this is quite useful. ICD-11 is digital health. That means system allows connections through standard API, and same package is also prepared for offline use also. What it means is technologically it is quite savvy, and that way it actually has its own advantages. Let us look into one or two specific areas, how actually this ICD-10 to, in fact, ICD-11, because that makes a lot of understanding for us to look into. What we basically call definition of sexual problems. ICD-10 was very clear. Sexual function covers various ways in which an individual is unable to participate in a sexual relationship as he or she would wish. But if you try to look at ICD-11, they have added lot many other terminologies. Sexual response is described as a complex interaction of psychological, interpersonal, cultural, physiological, gender-influenced processes. Any of these processes can get affected developmentally, which are described as syndromes that comprise various ways in which people may have difficulty experiencing personally satisfying, non-coercive sexual activities. So this is a much more broader and much more encompassing than actually what we talk about. When we are trying to talk about the chapter 17, sexual dysfunctions and sexual pain disorders. In fact, these are the two major categories that are actually available there. But there are multiple other sections possible to describe, and I'm not going to talk about these things at all at this particular juncture. So coming to the grouping of sexual dysfunctions, this new ICD-11 chapter on conditions related to sexual health, it has given goodbye to what we basically call the Cartesian separation of organic and non-organic conditions. In fact, non-organic used to be in case of ICD-9 in chapter on mental and behavioral disorders. Organic, most under chapter on diseases of genitourinary system. Substantial evidence regarding pathophysiology, interaction of physical and psychological factors, in fact, has led to the current understanding in majority of the psychiatric disorders, what we talk about, a biopsychosocial approach, or you may call it as holistic approach, or very earlier teaching what we call a psychosomatic approach. That means when we are trying to talk about there is an issue of drive or need if you are biological, motivational issues for psychological, and the wish, in fact, what we basically call part of the social functioning. So there are a few things we definitely need to look into what best and how best we can go about. In ICD-11, these categories have been brought grouping and have been subsequently reorganized. Sorry. Okay. In ICD-11, these categories have been brought together in a grouping and have been substantially reorganized, and a separate grouping of sexual pain disorders, which doesn't fall under this particular thing. Do this.
So I'm not able to see where the...
Okay. In addition, sexual dysfunctions are cross-listed in the mental and behavioral disorders section, and the frequent importance of psychological and behavioral factors in their origin and maintenance has been established that way. When you are trying to talk about gender incongruence or identity-related issues, it represents a substantial revision from gender identity disorders, which were actually what we studied in case of ICD-10. So conditions related to sexual health in ICD-11, there is actually provision for recognizing and identifying etiological considerations, and the of this medical condition could be injury, surgery, radiation treatment, associated with psychological and behavioral factors, use of psychoactive substances, lack of relationship factors, cultural factors, and actually the list goes. In the same fashion, coming to mental and behavioral disorders, there is a freestanding entry available. But this diagnosis should be used only when such factors increase the risk of suffering, disability, or death, and represent a focus of clinical attention and are not better explained by another mental or behavioral disorder. So that means how much significance that need to be put in this particular place. They may influence the course or treatment of the medical condition by constituting an additional health risk factor, by affecting treatment adherence or care seeking, or by influencing underlying pathophysiology to precipitate or exacerbate symptoms or to necessitate medical attention. So the range of, in fact, what we call medical and mental and behavioral disorders, neurodevelopmental syndrome, psychotic disorders to, in fact, personality disorders, the whole list is available where they can be actually spoken about.
Sir, can we be fast a little bit because we're running short of time for the breakout rooms.
Okay. Another few minutes. I'll just try to complete. The word satisfaction, in fact, here, the individual is satisfied with his or her pattern of sexual experience and activity, even if it is different from what may be satisfying to other people. And unrealistic expectation on the part of partner, discrepancy in sexual desire between partners, inadequate sexual stimulation, they are not valid basis for diagnosis. And that way, in fact, the range of categories, sexual difficulties actually have been documented, which should not be labeled as actually disorders. When we are trying to talk about sexual dysfunctions, a persistent or recurrent over a period of at least several months, in case of DSM-5, it is actually 6 months, occur frequently, although it may fluctuate in severity, and be associated with clinically significant distress. It can be treated as an acute cause and without waiting for that particular time duration, if there is a very specific cause, actually possible to do. There is a harmonized qualifier like temporal qualifier and situational qualifier. In fact, what we basically talk about, there are many of these aspects are necessary for actually reaching a conclusion. The partner, relationship, personal vulnerability, and many of these type of things are actually necessary. And how actually, that means lifelong generalized, lifelong situational, acquired generalized, acquired situational, unspecified. So there are the multiple ways, in fact, actually one can try to understand each of these disorders in this particular area. So what are these disorders? Hypoactive desire for dysfunction. Hypersexuality has been knocked off. Sexual arousal dysfunctions and ejaculatory dysfunctions, and sexual pain disorders, and gender incongruence and other related things. I will not go into the detail, but except highlighting the points. Hypoactive desire dysfunction, in fact, this has been separated out in case of DSM, but here it applies to both men and women. Sexual aversion disorder, just like DSM-5, this has been knocked off, and sexual pain penetration disorder under specific phobia, this is actually coded. Category would simply be classified as genital pelvic pain penetration disorder or under specific phobia in case of DSM-5. Condition related to sexual aids in ICD-11, the failure of genital response, lack of sexual enjoyment, and many of these type of things, actually, as we were trying to mention about the emotional satisfaction, these points actually definitely we need to keep in mind. So what are the commonalities? Why they are together? Actually, if you try to look at the neural pathways or neurochemical activities, in fact, there appears to be much of the things common for both men and women. In the same fashion, there are few differences also possible where they have been separated out, like say female arousal dysfunction and erectile dysfunction in case of men. In ICD-11 and DSM-5, premature ejaculation has been now labeled as early ejaculation. This does not distinguish between subjective experience of orgasm ejaculation in case of DSM-5, but this actually becomes something extremely important here. Sexual pain and penetration disorder includes the vaginismus and excludes dyspareunia, vulvodynia in case of ICD-11, which is exactly opposite in case of DSM-5. Coming to gender identity, we are all well aware that awareness of one's maleness and femaleness. Historically speaking, in fact, a lot of things have happened. Transvestism, earlier to transvestism, transsexualism in ICD-9, to transsexualism, dual role transvestism, gender identity disorder of childhood, other gender identity disorders. A lot of things came in ICD-10 and DSM-5. Currently, the gender dysphoria based on the distress actually the person experiences. So what is actually the difference? In fact, here the terms such as opposite sex, anatomic sex, all these things have been knocked off. Diagnostic guidelines do not implicitly presume that all individuals seek or desire full transition services to the opposite gender. The guidelines also explicitly pay attention to the anticipated development of secondary sex characteristics in young adolescents. That's why, in fact, when we are trying to talk about two categories, gender incongruence of adolescent adults, gender incongruence in case of children, there are a few important points. There have been criteria, at least two of these things one should meet. Two, in fact, for example, when you are trying to talk about childhood, they are much more stricter. A strong desire to be an instance that the child is of different gender, strong dislike for child's own sexual anatomy and anticipated secondary sex characteristics, make-believe or fantasy play. Ultimately, what one should understand is to meet these first two criteria is extremely important. The third criteria, what we talk about, it could be just a simple variance. And so this is one of the reasons why you should not make a diagnosis approximately till about 5 years. this ICD does not mention a specific duration of requirement or a minimum age at which it is appropriate to design the diagnosis, but this actually has been changed. So in conclusion, this is one of the important remarkable changes that have happened, that more reflective of current scientific evidence and best practices. Because it has been kept separately, each of the branches are, in fact, the specialists can work on this particular area. Multidisciplinary approach is very, very relevant. More responsive to the needs, the experience, and human rights of the vulnerable populations among them. More supportive of the provision of accessible and high quality healthcare services for the people. And what actually one can emphasize, this has kept us open to encourage further scientific and professional discussion. Keeping in mind there was a limitation and organizers were insisting on actually closing. I have just taken maybe I think less than 25 minutes. And with this, I'll stop here, except mentioning that what is this WHO comprehensive diagnostic formulation for persons with sexual disorders, which has actually two major components, what called multi-axial formulation and the second component, idiographic personalized formulation. Later in the breakout session, I'll elaborate on this thing. The clinical disorders, the axis 1, sexual disorders and other mental and general medical disorders has very positively to be documented. Disabilities, in fact, one can code it exactly the extent of disability. Multiple contextual factors it has brought in, and quality of life on a particular scale from 1 to 10. And second one, we are going to talk about, many people come and ask some treatment, some injection and some therapy, which can be just prescribed by somebody like that. It is not going to work that way. Contextualization of clinical problems, patients' positive factors for very simple to, in fact, the intensive therapy, the expectations for restoration and promotion of health. All these things need to look into. There are a lot many other aspects related to the current understanding, which we'll try to look into in the later part. With this, I positively thank the organizers for the opportunity what they have given and the patient listening. Thank you very much.
Thank you, sir. Thank you so much for the lucid presentation. In fact, I'm sure that the participants must have learned a lot and they must be having lots of queries, which and they will enjoy with the interaction in the breakout rooms. With this, I now hand over to the moderators so that we can go for the breakout room so that every participants can have one-to-one interactions in the breakout rooms and they can interact with the consultants or the faculties. Thank you. Thank you, sir, again. Thank you, sir.